So welcome. In today's session, we'll be talking about rheumatic heart disease. Okay, we'll be talking about rheumatic heart disease, and under rheumatic heart disease or rheumatic valvular disease, we discuss about the pathogenesis, then look at the morphology. In this video, I would discuss about the clinical features because that requires special attention. And I will create another video, a separate video where we can discuss about that. Now, welcome all. My name is Wallace Munyiri, and I'm the redactor. So let's start with the definition of rheumatic heart disease, which is the manifestation of rheumatic fever. Now, let me take a pen. Now, rheumatic fever is an acute immunologically mediated multi-system inflammatory disease that occurs after group A beta hemolytic streptococcal infections, usually after a pharyngitis, okay? And also with other infections such as skin infections. Now, rheumatic heart disease is the cardiac manifestation of rheumatic fever. Now, it is associated with inflammation of all parts of the heart, so all the three layers of the heart wall are involved, but valvular inflammation and scarring produce the most important clinical features. Now, the valvular disease principally takes the form of a deforming fibrotic mitral stenosis, and rheumatic heart disease is the only cause of acquired mitral stenosis. The others are congenital. Now, the incidence of rheumatic fever and thus rheumatic heart disease has been declining, okay, in many parts of the Western world. Why? Because there is improved socioeconomic conditions. There is also rapid diagnosis and treatment of streptococcal pharyngitis, and there is a decline, which is unexplainable, in the virulence of many strains of group A streptococci. Okay, this is in the Western world, but in developing countries such as Kenya, still this affects many people because the socioeconomic conditions are still not so good, and the diagnosis and treatment of streptococcal pharyngitis is still not that rapid, okay? Now, the most common affected age group, please note this, are children between the ages of 5 to 15 years, okay? Note that. And only 3% of these patients will develop acute rheumatic heart fever, acute rheumatic fever, sorry. Okay? And remember we said rheumatic fever is the one now, the cardiac manifestation of rheumatic fever is now the rheumatic heart disease, okay? So, pathogenesis, how does it arise? Now, acute rheumatic fever is a hypersensitivity reaction, okay? So it is not an infective condition, rather it is a hypersensitivity reaction classically attributed to antibodies. So antibodies directed against group A streptococcal molecules that cross-react with host myocardial antigens. So it is a hypersensitivity reaction, not an infectious disease or not an infectious process. Now, in particular, antibodies against the M proteins of certain streptococcal strains, strains 1, 3, 5, 6, and 18, usually bind to the proteins on the myocardium and cardiac valves, and this cause injury through the activation of complement and the FC receptor-bearing cells, including the macrophages. Now, CD4 positive, these are the T helper cells that recognize streptococcal peptides, can cross-react to the host antigen, and this can elicit a cytokine-mediated inflammatory response, okay? Now, the characteristic, there is a 2 to 3 week delay in symptoms onset after infection is explained by the time needed to generate the immune response. So at first, the patient will have a group A streptococcal infection. Okay, then after 2 to 3 weeks, they develop the rheumatic fever. And that delay is the time needed now to generate the antibodies and which now mediate the immune response now. And by the time of 2 to 3 weeks, when now rheumatic fever is developing, the streptococci will be absent from the lesions, okay? Since only a small minority of the affected individuals develop rheumatic fever, genetic susceptibility to the development of cross-reactive immune response is likely in those affected. So there is a genetic component. Now, the deforming fibrotic lesions are the predictable consequence of healing and scarring associated with the resolution of acute inflammation. So the valves get inflamed, then during healing, there'd be scarring, okay? And this will form fibrotic lesions, and that is what now will lead to the rheumatic valvular disease. Now, just to remind you, the non-suppurative complications of group A, beta hemolytic streptococci, some streptococcal antigens show molecular mimicry with human antigens, okay? And this leads to cross-reactivity, okay? In that antibodies, they are produced against these antigens, but they cross-react with normal human tissues, okay? And this can lead to acute rheumatic fever, post-streptococcal glomerulonephritis, guttate psoriasis of the skin, reactive arthritis, and the pediatric autoimmune neuropsychiatric disorders associated with Streptococcus pyogenes, the pandas. No. Antibodies generated against the cell or M protein will cross-react to the myocardium, okay? Now, those generated against the C carbohydrate of the Streptococcus will react with cross-react to the cardiac valves. Those generated against the streptococcal cytoplasmic membrane will react with the glomerular vascular intima, leading to the post-streptococcal glomerulonephritis. Those against peptidoglycan will react with the skin antigens, hence the guttate psoriasis. Those against hyaluronic acid of the streptococcus will cross-react with the synovial fluid, hence the reactive arthritis. Okay, but today I want us to focus on these two. Okay, antibodies against these are the ones which produce acute rheumatic fever. The cardiac manifestation of acute rheumatic fever, the rheumatic heart disease. Now, morphology. Acute rheumatic fever, or let's call it RF. RF is characterized by discrete inflammatory foci within the variety of tissues. Now, the myocardial inflammatory lesions are known as Ashkoff bodies, okay? And these are pathognomic of rheumatic fever. These are they are collections of lymphocytes, primarily T cells, scattered plasma cells, these are your activated B cells, plump activated macrophages, which are known as Anishko cells, associated with the zone of fibrinoid necrosis. Now, Anishko cells have abundant cytoplasm and nuclei with chromatin that is centrally condensed into a slender, wavy ribbon, the so-called caterpillar cells. When you look at the nuclei of these Anishko cells, the chromatin will be somehow slender and wavy like this. Okay, so you will see a cell, and within the nucleus, you will see that, and they will have a large cytoplasm. And this is the reason why they are known as caterpillar cells, because the chromatin looks like a caterpillar. Now, during acute rheumatic fever, Ashkoff bodies can be found in any of the 3 layers of the heart. Ashkoff bodies during acute rheumatic fever can be within the pericardium, the myocardium, or the endocardium, including the valves. Hence, rheumatic fever is said to cause pancreatitis. So pancreatitis is an inflammation involving all the 3 layers of the heart. Now, the salient features include the pericardium may exhibit a fibrinous exudate, which generally resolves without any sequelae. Okay, so that fibrinous exudate presents as a bread and butter appearance. I will be showing you that. Now, the myocardial involvement, that is the myocarditis, takes the form of scattered Ashkoff bodies within the interstitial connective tissue. Now, valve involvement, that is within the endocardium, results in fibrinoid necrosis and fibrin deposition along the line of closure of the valves, forming 1 to 2 millimeters vegetations known as Vegetation. Okay, and this cause little disturbance in cardiac function. Okay, so I've said that pancreatitis, because it is involving all the 3 layers, and we have, so if it involves inflammation of the endocardium, endocarditis, myocardium, myocarditis, pericardium, pericarditis. Now, due to the fibrinous exudate of the pericardium, there'll be the bread and butter appearance, the fibrinous exudate. Now, within the myocardium, there will be the Ashkoff bodies, and these are pathognomic of acute rheumatic fever. Within the endocarditis, there will be valvular endocarditis, where there will be the vegetation, the velocide, and there will be mural endocarditis, which will present as McCallum's patches. Okay, and these McCallum's patches are due to the valve which is most involved, okay, in the valvular endocarditis is the mitral valve, and due to that, there'll be mitral regurgitation, and this will induce irregular thickening in the left atrial wall, the left posterior atrial wall, and that irregular thickening are now what are known as McCallum's plaques or patches. And I've said they are most common in the left posterior atrial wall. Now, this is the bread and butter. You can see here we have the pericardium must be cut. That is the fibrous pericardium and the parietal area of the serous pericardium to expose now this. You can see this is the epicardium or the visceral area of the serous pericardium, and you can see the typical bread and butter appearance, and this you can see the fibrous exudate here. Okay, so okay, then the velocide or the vegetations. Now, acute rheumatic mitral valvulitis. This image shows acute rheumatic mitral valvulitis superimposed on chronic rheumatic heart disease. Now, there you can see the small vegetations, these here, okay, small vegetations along the line of closure of the mitral valve leaflet. And you can see here, these are the chorda tendini, and you can see they are fused from previous episodes of rheumatic valvulitis. And you can see they are thickened and fused, these chorda tendini, okay? Now, more about these vegetations. In rheumatic fever, you will find vegetations also in other conditions such as non-bacterial thrombosis, in systemic lupus erythematosus, and also in infective endocarditis. But the vegetations in rheumatic fever are usually small and warty. They are firm, they are friable, so they can be propagated. They occur along the lines of closure of the valves, especially the mitral valve. They are sterile, so, and they do not cause destruction of the underlying valve or the myocardium, okay? And as I've said, they are found in rheumatic fever. Now, these are the Ashkoff bodies. You can see the area of central necrosis here, and then you can see it is surrounded by these Anishko cells or the caterpillar cells, okay? And an Ashkoff cell, which is fused caterpillar cells. Okay, and you can see a cross section of an Ashkoff cell and a longitudinal. You can see in the longitudinal section, you can see the chromatin within the nucleus is somewhat wavy. So caterpillar, okay? So these are the Ashkoff body, okay? And these are pathognomic of acute rheumatic fever. They are found within the myocardium. Now, still on the morphology now, chronic rheumatic heart disease is characterized by the organization of acute inflammation and subsequent scarring. Now, Ashkoff bodies are usually replaced by fibrous scars, so that regions are rarely seen in chronic disease. Now, most characteristically, valve, please note this, valve cusps and leaflets become permanently thickened and retracted. Now, the mitral valve exhibit leaflet thickening, okay, and the valve commissure fuse, so there'll be a commissural fusion, shortening and thickening and fusion of the chorda tendini. So the chorda tendini shorten, thicken, and become fused. I had showed you that. Now, fibrous bridging across the valvular commissures and calcification usually create what is known as fish mouth or buttonhole stenosis, especially of the mitral valve. Now, microscopic examination shows neovascularization and diffuse fibrosis that obliterates the normal leaflet architecture. Okay, so this, so let's start with this image here. Okay, I start with this image. You can see the fish mouth. You can see this opening here has the fish mouth appearance. Okay, so this is so in this image there is diffuse so this is mitral stenosis with diffuse fibrous thickening and distortion of the valve leaflets. So there is commissural fusion, okay? So you can see the valvular commissures are fused, okay? Okay, so there is a commissural fusion, thickening and shortening of the chorda tendini, and also in this image here now, this image, the anterior leaflet on the open rheumatic mitral valve, and there is some form of neovascularization here. So there is some form of neovascularization. Let me erase that so that you can see the neovascularization. So there is some form of neovascularization along here. Okay, there is a form of neovascularization around there, and this now this is a let me take back the pen. Sorry for that. Now this is a surgically removed specimen of the rheumatic aortic stenosis, and you can see thickening and distortion of the caps with you can see these leaflets, and you can see fusion. Yeah, remember the aortic valve has 3 leaflets, and you can see the commissural fusion. Okay, so and how thickened they are. Okay, and I also want you to notice that in this, you can see if this is the mitral valve, what is above it is the left atrial chamber, and you can see how marked, how dilated. So there is marked left atrial dilation here, okay, due to the regurgitation, okay. When due to this mitral valve stenosis, there will be now regurgitation, okay. So what are the consequences of that? Now, the most important functional consequence of rheumatic heart disease is valvular stenosis and regurgitation. Now, stenosis tends to predominate. Now, the mitral valve alone is involved in 70% of the cases, and combined mitral and aortic disease is seen in 25%. Now, the tricuspid valve is less frequently and less severely involved. And now the pulmonic valve almost always escapes injury. So I'll be showing a table with that. Now, with tight mitral stenosis, the left atrium progressively dilates owing to the pressure overload, and this precipitates atrial fibrillation. Okay, now the combination of dilation and fibrillation is a fertile substrate for thrombosis because the epistasis. And remember, Vicos triad, we said in the triad, let me draw that triangle. There is hypercoagulability. No, at the top here is endothelial injury. Then here is hypercoagulability. And here you put hemodynamic disturbances. That is either blood stasis or turbulence. Now, when there is stasis, that is forms a very fertile ground for thrombus formation. Now, and the formation of large mural thrombi. Okay. Now, long-standing passive venous congestion gives rise to pulmonary vascular and parenchymal changes typical of left-sided heart failure. You can, because of that stenosis, there'll be a backward failure, and that backward failure will lead to features typical of left-sided heart failure, which include a pulmonary edema, and which worsens with when the patient lies in a recumbent position, leading to the paroxysmal nocturnal dyspnea. Now, in time, this leads to right ventricular hypertrophy and failure. Remember, we said that right-sided heart failure, the most common cause of that is left-sided heart failure. Now, with pure mitral stenosis, the left ventricle generally is normal, okay? So valves, we said the commonest valve to get involved is a mitral valve, leading to mitral regurgitation. Second most common is the aortic valve. Third most common is the tricuspid, and the least frequently involved is, this should be valve, not valve, is the pulmonary valve, okay? So I think we've come to the end of that. Thank you for your time, okay? And follow for more of med content. Next, I'll be discussing about clinical features of rheumatic heart disease. Don't miss out that. Thank you.